Welcome to my podcast. My name is Dr. Brendan McCarthy. I'm the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. By the time this airs, I believe I will be in the new office. If not, I will be there in a couple of weeks. But we are moving into a new office. Justin, our producer, is going to be working with us there as well, and we should be putting out some cool videos from that location. I know I don't talk about my practice very often in here, and I lead with saying I am the Chief Medical Officer of Protea. And I know if you've listened to any of my videos, you know I'm not using this as a marketing tool for my practice at all, even a little. I'm still super proud of my practice. It's just been my life's work. And I was just speaking with Justin and I were just talking about this. And some people pursue medicine as a business. And I've done some recent reels on that where people go into this because they just want to make money. And I've actually spoken to other physicians and they'll say things like, this is going to be my moneymaker. That's really off-putting to me, to be honest with you. I started this originally because I saw the impact progesterone had on one woman once. That was it. And I thought to myself, how can I keep doing this? How can I keep playing this role? Because it was so rewarding to sit there with someone who wasn't sleeping, chronic anxiety, her life's out of control. And those of you out there who have experienced this, you know what I'm talking about. And those of you who have family members that have experienced this, you know what I'm talking about. Imagine being on the other side of that as a care provider and writing a prescription for something that is benign, natural, inexpensive. It was relatively very inexpensive when I first started practicing progesterone. And so the business was primarily about how can I bottle that lightning, so to speak? How can I continue being in this space with these people and providing that service? So the business for me of medicine is how can I create a system where I'm able to continue providing something that is that rewarding, that is that act of service, and brings that kind of joy. You know, it is a not even worthy of arguing this, that, you know, we all know that money is not what brings us joy in life. It's people will then come back and say, well, money doesn't, but it helps you buy the things that will bring joy. I want to say that it really, for me, what brings me joy, I can speak for myself, are those acts of service, like when we do the Q&As and when we engage with you. So I'm very proud of my practice growing, because it's grown not because of me, but because I've been able to meet more doctors with like-minded approach, and I've been able to work with some really wonderful, creative, and thoughtful people. And so my practice has grown due to that mission and due to that bringing people around me that share my philosophy and that belief of, like, this is something we want to do to be helpful with every one of our patients. It's just such a rewarding thing. So I'm proud of my practice. And I want you to know that when I do this podcast, it's not marketing it, but I just would like to be proud of it for a moment. So anyway, PCOS, it's a big deal. Let's talk about it. Before we do, scroll down and subscribe, like, and share. We already did one episode on this, and I was watching it last night, and I want to add to it. Sometimes I watch a reel that we do, a video we do, or I'll watch the reels associated with it, and I'll see what I'm saying, but also see how my brain works. And how my brain works is not always, yes, my wife, my brain is not the easiest one to follow sometimes, because I'll just jump ahead of things. I'll just take these steps and I make those leaps. Why I'm saying that is because polycystic ovarian syndrome is a very complex thing. It has so many moving parts to it. And in order for us to understand it, for you to understand it, and when I say us, I mean, knowledge is only as valuable as you're able to share it. You know, that's the only value in knowledge. There's only value in things is what you could share from it. So the only true value of this is my ability to share it in a way that's meaningful to you. So I thought a lot about rewording things a little bit or just repeating it, because I believe as you repeat things, you create a depth of understanding. So I'm going to go down a little bit further into what I discussed last episode, and I'm going to detail it a little bit further, be a little bit more into the biochemistry, not too much. I promise not to get too dragged into the biochemical nuances of this, but just enough so you get an understanding of the therapies and why they do what they do and why I'm going to recommend what I'm going to recommend. So I'm going to do that today on today's episode. So I'm going to dive into that now. In order to understand polycystic ovarian syndrome, we really do need to understand the cycle of a woman and all the parts of the endocrine system that are at play during a cycle and how they go wrong or go awry in PCOS. And that way I can discuss with you how to correct it. So let's start with a normal cycle. Normal cycle for a woman begins when estrogen and progesterone, everything's at a low state. That's around menstruation. Everything's that's low level. And when that occurs, your brain reads that. Now your brain, the pituitary, is like a thermostat. And that thermostat's always looking for a temperature. It's like in your house, if it gets too hot, the air conditioning turns on. It gets too cold, the heater turns on. But that's because the pituitary is sending the signal to turn things up or turn things down, because there's a fine range. So your pituitary is always trying to assess how much you have of estrogen, how much you have of progesterone, thyroid, cortisol. It's always looking at your endocrine system and is trying to regulate the levels of hormones you have in order to keep things in their tight range. And that's the signal they send down. So when your brain sees no estrogen or low estrogen, which is the beginning of a cycle, it's going to release something called follicle stimulating hormone, or FSH. Now, an FSH surge goes down to the ovaries and says, hey, let's have some estrogen. Let's do this. So it extends out to those follicles in each ovary, and it stimulates your body to generate more follicles or bring follicles to the fore. Now, those follicles are being stimulated by follicle stimulating hormone, then start to secrete estrogen. So estrogen levels start to rise throughout the body. Now, that estrogen that's coming from these follicles starts stimulating all those parts of you associated with fertility. The breasts, the uterus, the cervix, the ovaries, vaginal tissue, collagen. It's also there for your bone density. It's good for cholesterol, neurological function. I mean, it is everywhere. And that estrogen does the job it does. And we like that. We love that. Estrogen has such a bad reputation from the past few decades, and we really need to get rid of that bad reputation because it's an important part of you. And just like anything, too much is not good, too little is not good. What's good is what's right. And that's where you're supposed to be. So your brain sends that signal down, FSH, to the ovaries. The ovaries then return, the follicle stimulating hormone stimulates the follicles. The follicles then make estrogen. Estrogen levels are higher now, and they keep going up. As they keep going up, the follicles releasing estrogen. The other thing it does, the estrogen from the follicles goes back to the ovaries and stimulates the follicles more. It's a feed-forward pathway. So these follicles are growing and becoming more full. There will be one follicle, maybe two, that are going to become dominant follicles. Those are the ones that are going to have the eggs that you're going to be releasing at that cycle when you ovulate. Now, when you hit a certain level of estrogen in your brain, you hit a certain height, it goes up to a certain point, you'll have something called a luteinizing hormone surge. So if your estrogen gets too high, your brain's like, whoa, all right, that's it. Hit heights of estrogen. Let's calm it down. So you send out LH from the pituitary because that's the thermostat. It sees estrogen go too high, message gets sent down. So now LH goes down to the ovaries and it stimulates the ovaries to shift. Those follicles are now converted into something called corpus lutea, or white bodies. That's a Latin term for it. It's very creative, white body, corpus lutea, because when you look under a microscope, it's white and it's a little body inside. You get it. Those corpus luteum, they start to release progesterone. Now, with that said, the dominant follicle on each side, they ovulate. One or both, or sometimes neither, but it happens. But you have ovulation at that point. That's what luteinizing hormone does. So now these follicles are involuted. They now release progesterone. Now, progesterone goes back to all that parts of you, all the parts of your body associated with fertility, and it matures them. And it plays a complex role here. And I could spend hours talking about progesterone with your endocrine system and your brain and everything, but I'm going to try and do my best to be very surface with it because we're going to do another episode out here, I think, second from this, next after this, or maybe the one right after that. We're still not sure how many more I need to do on this. But progesterone, it's the thing that matures the lining of the uterus. And when I say that, the lining of the uterus is growing, growing, growing with the idea you're going to get an egg here pretty soon. We need to make this ready to nurture that egg. So you need a thicker lining. Progesterone goes back to that and calms that down and helps structure that tissue better. It gets blood flow to the tissue. Okay, that's the critical thing. It improves blood flow or perfusion to the lining of the uterus. Remember that. We're going to come back to this in a sec. It goes back to the breast tissue. It lobulizes that tissue. It helps maintain its health and its integrity. It doesn't prevent the estrogen from overstimulating that tissue. Progesterone plays that important role. It plays a role throughout your body with balancing out the impact of estrogen causing growth. When it comes to collagen and fat distribution, estrogen is what gives a woman curves because that's the impact estrogen has on that adipocytes located at your hips and breast tissue. Yes, progesterone plays a role in that as well because progesterone inhibits that from being excessive. There's been so many studies that show that when you give a woman perimenopause and postmenopause, if you normalize a woman's progesterone, it really plays a role with improving the waist-hip ratio. It brings that waist-hip ratio in because that's the benefit of progesterone. So progesterone plays a role also with lipolysis, lipogenesis, or just basically adipose signaling and growth and distribution, etc. Progesterone is a key part of this. Then when you go a certain period of time and there hasn't been a implantation, there hasn't been a signal from the uterus that you're pregnant, then everything drops off. The luteinizing hormone and follicle stimulating hormone, they drop off. Luteinizing hormone drops off, estrogen is already lower, progesterone drops off, and then you have menstruation. That's what that point is. So, what on earth is happening with PCOS? Good question. I love this dog. Polycystic Ovary Syndrome is, in essence, you're not ovulating. You're just not ovulating. So you get stuck with the estrogen levels. You get stuck with the estrogen levels being higher because that's the follicular phase. That's those first 2 weeks. And as the estrogen levels are higher, it stays higher. Imagine you didn't ovulate. There was no signal. There's no LH surge that went down to the ovaries and saying, hey guys, that's enough estrogen. Let's make progesterone. No. So all month long, you're going to have that estrogen. That lining of the uterus becomes unstable and keeps getting thicker. You're going to see body tissue being overstimulated by that estrogen. Now, there's a couple things that go on with the luteinizing hormone that I want to bring up here. Luteinizing hormone, in some cases, are not going to be elevated, but you're still diagnosed with PCOS. I've seen this. This drives me crazy. See, a characteristic that we should be aware of with ovulation is, are you not ovulating? PCOS is, in essence, you're not ovulating. So estrogen is allowed to stay dominant and run buck wild through your body all month long. Now, here's where it gets funky. You may not be ovulating because your ovaries are not responding to luteinizing hormone. You may not be ovulating due to luteinizing hormone being blocked at the pituitary due to prolactin. No matter what, you're not ovulating. There's genetic components to this. There's all these other things that they associate with being, vicious cycle of what causes it. But at the end of the day, the point is you're not ovulating, and we need to know why you're not ovulating. When you're not ovulating and you have high luteinizing hormone, say luteinizing hormone's high, you're not ovulating due to a progesterone irregularity, prolactin irregularity, you're not ovulating for some other reason. So say you have luteinizing hormone insensitivity. That's when you're gonna have high luteinizing hormone. So that's where things get spicy. When luteinizing hormone is allowed to be elevated, luteinizing hormone is going to go back to the ovaries and the thecal cells, and that's going to stimulate your body to start making more androgens. That's where you see that testosterone and androstenedione. You see those irregularities, first androstenedione, then testosterone downstream from that. But that's how you're going to find this, is this luteinizing hormone elevation. Luteinizing hormone also stimulates insulin, and your insulin levels getting high enough, there's your weight gain, and high levels of insulin create that insulin resistance that you see with these women. So women who have PCOS with this issue, they're going to have high insulin fasting, and they're going to have normal glucose because that's being stimulated. Insulin's being stimulated through that LH pathway. Luteinizing hormone is doing that. I want to focus a little bit more on prolactin before I talk about the high LH causes and what does that. But I want to talk about prolactin just a little bit more today because that is a A key part of this that gets overlooked, and when I see patients coming to my clinic who've been diagnosed with polycystic ovarian syndrome, they are not ovulating. Truth. They're not ovulating. I get that. What I have a thing with is that why aren't they ovulating was never fully investigated. And so they weren't always had the lab work done to understand that. And this is a key part of diagnosing and treating. In the normal clinical setting, all you want to do as a standard physician who's just kind of going there and just doing like kind of lazy medicine is you're just going to give her birth control to suppress everything, and you're going to give her, something to block testosterone, and you give her something to improve insulin sensitivity, and you call it a day. But that's just punching those holes, the problems. It's just basically that's checking off the boxes. Okay, I got these symptoms. You're good. Goodbye. And I mentioned that in my last episode. This is very frustrating to me as a doctor to see that, because that's not real medicine. That's stabilizing the care of a patient, sure. But real medicine, I believe, is stabilizing care of the patient and understanding the cause and doing everything in your power to heal, cure, fix, whatever you can do for this person. That's our job. So when a person is not ovulating, we want to know why, because that helps us find a cure. So say the person has... They have prolactin elevations. They're elevated. And prolactin, as I mentioned before in a previous episode, prolactin is a message that comes from pituitary saying, I'm nursing. It's basically, it stimulates nursing. It's something you release as a woman when you're nursing. Men should not release it, but it's one of those endocrine signals that happen. And why it's important is because it stops you from ovulating. It's not perfect, but it does a pretty darn good job. So when you're nursing, this is why women who are nursing don't conceive or should not be able to conceive. Sometimes they do, and that's not the best thing to do during that time. Because if you're nursing and you're trying to, you're pregnant with a baby, there's going to be some nutritional irregularities start happening here that are not good. So prolactin is one of those natural birth control things. It stops ovulation that way. Now, sometimes prolactin is high even though you're not nursing. And that will stop ovulation. We want to know this. This is the part where it's going to get heretical for you, which means I'm going to go a little off the beaten path. And most medical doctors hearing me will kind of not like this. But if you sit down and you think about it with physiology and pathology, you sit down and then also you apply it clinically, you realize, this is actually makes sense. So prolactin, if it's very elevated, let me talk about that one first. If it's very elevated, that could be due to a tumor, pituitary adenoma. It's not a death sentence, but it's important to know. Because you want to diagnose that. You do an MRI, you look at the patient, and you'll find out whether this is a pituitary adenoma, and then there's medications you prescribe for that. That brings it down. So that's one cause of prolactin being elevated, and it'd be high. It'd be like 100 or higher, 50 or higher. That's what happens. And you want to screen for that. But sometimes your prolactin is in the range, but it's the high end of the range. It's at a level that's equivalent of nursing. And you shouldn't be nursing if you're not pregnant or didn't have a baby. Prolactin shouldn't be that high. I've seen this in my clinic before, enough to drive me out of my mind, because it's such an important thing to address. So if your prolactin has a range up to, I think the new range is higher now, but the range says 25 or something is the upper end of the range, and lower end of the range is 4. The more you move towards 25 on that range, even though you're in the normal range, the less likely you are to ovulate. So if you have a patient presenting to clinic who's not ovulating and their prolactin is 4, you want to look at other reasons why they're not ovulating. But if you see their prolactin somewhere around 12, 13, you want to understand that, because that would cause her to have anovulatory cycles. So what that would mean is that her prolactin, while not high enough to be a tumor, it's high enough to inhibit this cycle. And in turn, ultimately, fertility and all the things that go along with ovulation. So what causes those elevations, those micro elevations in prolactin? What causes that? I'm very fond of pointing out how gluten does this. And I don't see it every time, but gluten does that. Wheat does that. There's nothing wrong with gluten or wheat, just like there's nothing wrong with pollen. But sometimes we react to it inappropriately. And it is important for your physician to find that. So if your prolactin is above 4, and you're not ovulating, say it's like 12 or 13, 14, you want to take gluten out of your diet and then rerun the lab after a month. If the prolactin went down, that's what it is. Now, if we're not sure, you want to prove it again, eat a bunch of gluten, rerun the prolactin. Then do no gluten again and test it again. Whatever as many times you need to see that that's the case, do that. That's important to rule that out right away, always with women. Any woman who's not ovulating well, any woman who has low progesterone symptoms, anything like that whatsoever, prolactin. Where is it? Why is it? Why is it where it is? What else could cause prolactin elevations? Pharmaceuticals. There's a lot of medications that'll do it, and if you're taking one of those pharmaceuticals, I'm sure they educated you on it. I hope they did. But I want to pick out of this a little bit, not go too far into it, is oral contraceptives. Oral contraceptives have been, in my clinic, obvious causes of elevated prolactin. They do that. Not every contraceptive, but enough do. And that's something they don't tell you about. So oral contraceptives, which is ironic because we use oral contraceptives with PCOS to suppress, their estrogen and suppress that excessive level of estrogen. It's also increasing your prolactin, which is not something we want increased. What else causes elevated prolactin? And this is what I want to drill into today more. Prolactin can be elevated when you're under severe stress. Real stress. Prolactin is a stress hormone as well. There's a lot of research. I think I'm going to do an episode on prolactin by itself as a stress hormone because it's important to discuss. I've known that prolactin is elevated in times of severe stress, since I started practicing medicine. I think I remember a case, and I know this was in about 2004, 2005. I remember this one case, a young lady who was just having prolactin elevations fluctuated, and she had really an unhealthy home. A lot of stress, a lot of this really traumatic. And I knew it plays a role, but I was never able to kind of isolate the case and say your stress reduction in your life has improved prolactin because she had so much going on. And I did not see her long enough to see that movement in her life. But recently I had a case that just sits in my heart. There's one case of a patient, and it really does sit in my heart. Because as a physician, our goal always is to try and find a cure for you without you needing us ever again, kind of thing. That's what, you feel like you win. You're winning. I'm a winning doctor. That's it. So this patient, had a lot of stress in her life and a lot of trauma that she's working through. She went into deep therapy, self-care, a lot of internal work. Before that, when I first saw her, not cycling, a lot of PMS, a lot of PMDD, a lot of those emotional components. And I'm running her labs and I see her prolactin is elevated. She's not a PCOS case, but I'm saying if she had high enough prolactin, it would have been, but still not specifically PCOS. She didn't have all the other symptoms, but just she presented to me for anovulation and she's presenting to me for anxiety, depression. And so prolactin elevation, and I did MRI and we saw it seemed like a microadenoma was going there. It was very small. And so I prescribed cabergoline, which is the medication that you use to stop that. And I relabbed to make sure her prolactin hit the right level. And it worked. Brought it down. We're good. 6 months later, she came to clinic and she had no prolactin whatsoever. No prolactin whatsoever. She should, with the cabergoline, have had some. I didn't stop it to zero. There's reasons why you don't want to fully suppress the pituitary unless you know what you're doing with that. I did not fully suppress the prolactin with the dose of cabergoline I gave her. It should be 4, but it went to unmeasurably low. And so I asked her, what's different? What's going on? And she had gone to therapy. She's a wonderful human. She had gone to therapy and she had really dug in the dirt, really did a really extensive inner work here. And it had changed her life. She'd done a lot of changes to her life. And so we have the suspicion, what if we were wrong that it's a prolactinoma? What if this only was severe stress causing this? So I had her stop cabergoline and I ran her prolactin. Prolactin went to about 3. That was it, 2.6. That was it. So that was a case I was able to see how stress impacts, and the reduction of stress, improvement of mental health improves that prolactin levels, and how it's going to play a big role in someone's future fertility, but also how it plays a role with PCOS type symptoms where women aren't ovulating and they have the anovulation, they have the endometrial lining thickening and all the other symptoms. So that was important to be aware of that. So again, when you have the diagnosis of PCOS and you may not have all the hirsutism, which is the hair growth and all those sensitivities, it's still worth running that prolactin more than anything, because that may be what's happening here. And your treatment could be either dietary, it could be stress management, or it could be a microadenoma, easily treated. Those three things I think are so important to take to your doctor and take to your care regarding PCOS, because I think those are things that are very often overlooked that I've witnessed in my practice. And those are some easy things to solve with using those three things. I hope this helps. Next episode, we're going to come back. We're going to talk a little bit more about progesterone. We're going to keep talking about PCOS because it's so important. I want you to know I'm with you with this, and I care about this. I've been reading your comments. Justin and I love the comments. And the YouTube is the best. I see the ones on the reels. I see them all. And I want you to know your feedback means everything to us, because we do this as a labor of love, because this is something we love to do. So please continue with your comments. Please continue with your input. Please help us continue making this to be helpful to you. And then like, share, and subscribe. And I will see you at the next episode.